ladies and gentlemen, my colleagues, the Arab world, we have again this webinar from the SOI in the frame of Basic and Clinical Science course. And we have again Mr. Professor Bornfeld from the University Hospital, from the University Essen Duisburg and Düsseldorf Eye Center. As we introduced him in the last time, he is one of the experienced leading professor in the onco-ophthalmology, and under his leading the ophthalmological department in the University Hospital Essen. He could contribute and reform the guidelines of the tumor surgery, tumor eye surgery, and therapies. So we are very glad to have him again, and we have to thank him again for sharing us his experience. I give you the word, Mr. Professor.
Yeah, thank you very much for being here. It's my pleasure, definitely. So we start. It's a heavy schedule, unfortunately, I'm afraid. So I hope we make it all. We have an hour, don't we?
Sure.
Yeah, okay. So let's start. So let's start with the most frequent malignant tumor in the adult, of course, which is a malignant melanoma of the uvea. And this is what the typical appearance of such a tumor is. It's a pigmented lesion in the choroid with exudative retinal detachment and orange pigment, and that makes a typical clinical diagnosis of a malignant uveal melanoma. This is another tumor, again, very typical, a mass of choroidal pigmented mass close to the macula at the posterior pole with exudative retinal detachment and lipofuscin flows on this orange pigment on the surface of the lesion. And if you see such a lesion, probably it's very likely that this tumor is a malignant melanoma. Fluorescein angiography is very typical of a malignant melanoma. It's probably not needed in clinical routine, but if you do such a fluorescein angiogram in a tumor, you will see a very typical staining of the tumor. It's what's called a double circulation pattern. When you start with a fluorescein angiogram, the tumor appears dark. And if you go on with a fluorescein in the angiogram, you will see that the tumor vessels are stained before the dye is getting into the retinal vessel system. And then in the later stage, the whole tumor is pooling the dye and it's just glowing up in fluorescent. It's glowing a fluorescent, hyperfluorescent mass in the choroid, and that is a very typical fluorescein angiographic pattern of a malignant melanoma. MRE imaging is helpful. It's not needed as a routine, probably, unless you do not plan to do any surgical treatment, but it's a typical appearance of the tumor in T1 and T2 weighted image and with a mushroom-shaped image. Sometimes in clinical practice, it may be overlooked that a peripheral tumor in the ciliary body has episcleral dilatation of episcleral vessels, or the vessels of dilatation of episcleral vessels. And this may be mistaken for episcleritis. And we do see a lot of patients who have been treated for months and years with a diagnosis for episcleritis, but this is a tumor vessel enlargement due to the intraocular mass. So whenever you see a patient with such located, focused episcleral dilatation of vessels, you always look into the eye, make sure you have seen the patient with white pupil. Nevus of Ota are rare, but they're very typical. When you see such a patient having melanosis of the eyelids, melanosis of the sclera of the whole eye, brown dark eyes, and a diffuse brown staining of the whole posterior segment, this is Ota's nevus, and these patients unfortunately have a very bad prognosis, and they have a very high risk of getting malignant melanomas. Another pitfall in the diagnosis of malignant melanomas of the uvus are diffusely infiltrating malignant melanomas. And these may be mistaken. And that is a patient who has been seen in the upper left, is the initial presentation of the patient, and the patient didn't want to do any further treatment or diagnosis. And we have seen the patient 6 years later, and what you see what happened, that's a tumor which infiltrated the choroid, the anterior segment, secondary glaucoma, rubeosis of the iris, and of course, an extraocular extension, of course, and This is, of course, a very malignant tumor, and diffusely infiltrating uveal melanomas are a real pitfall. That is what the definition is made. These are tumors with a height of less than 20% of the basal tumor diameter and a very large tumor diameter, more than 80 millimeters. Usually these tumors have an infiltration of the optic disc, and some of these are called ring melanomas when infiltrating the anterior segment, the anterior uvea, and they have a significantly increased risk of metastasis. You see on the left such a case with diffuse infiltrating melanoma of the whole choroid and massive extension of the tumor into the orbital fat, and that patient, of course, died because of metastatic disease. Malignant melanomas of the iris are different. What you see here is a patient, what you see on the lower right is a wedding photograph of that patient. And if you look closely to the eye, you will see that there's a pigmented lesion in the left eye, temporal and inferior. And that is the same patient 42 years later. And so it took 42 years from stage 1 on the lower right to stage 2 on the upper left. So these tumors, as a rule, are very slowly growing. And there have been several papers dealing with the risk of iris melanomas, and the risk of iris melanomas for seeding metastasis is it's completely low. And that is a large series published some years ago. And the essential take-home message of that series is there have been no metastasis from patients with iris melanoma in stage T1. These are tumors not touching the iris root. So whenever you see a pigmented lesion in the iris, which does not touch the iris root, the risk of the patient to get metastasis is very low. And the whole series, the risk of metastasis is lower than in all other uveal melanomas. That's such a case with an iris melanoma, and 3 years later, the same patient. What makes a diagnosis, in clinical practice, the most complicated or tricky or most pitfall is what makes a differential diagnosis between a nevus and a melanoma. And that is a pigmented lesion with lipofuscin and just a flat pigmented lesion and lipofuscin on your right in autofluorescence. And 6 months later, this lesion has clearly grown. Just look at the green arrow, and there's no doubt that lesion has become larger. And we should know that what is called a nevus, or better is called a melanocytic lesion of the choroid, is the most common benign intraocular tumor in Caucasians. So it's not rare. And the prevalence is approximately 5 to 6%. And nevus are not harmless. They are a potential threat to vision due to exudative retinal detachment and secondary choroidal neovascularization. But the transformation rate to malignancy is calculated by 1 to 8,054. So you have to see close to 9,000 patients to find one with a malignant melanoma. So what may help? The Shields group in Philadelphia has been very busy to publish on a risk scale, and they did a multivariate analysis for risk factors. This is the German text, unfortunately, left in the slide, for the risk factors for growth, not for malignancy, for growth. And they looked at thickness, subretinal fluid, symptoms, orange pigment, specific ultrasound characteristic of the tumor and the diameter. And that was called with an acronym, which is TFSOM-DIM, TFSOM-DIM. This is the acronym which is widely used in literature and is very widely used in literature. And that is a formula for a hazard ratio and a risk factor for patients with a melanocytic lesion, nevus, to have growth of that lesion. Growth is may not be malignant. So this is such a patient from the series with what is called a high-risk nevus with orange pigment and subretinal fluid. And that's the OCT of the same patient. And that lesion definitely grew. And this is the ultrasonography of the tumor with a specific acoustic hollowness, that again is a risk factor in the Shields classification. Third-source OCT may be helpful. Third-source OCT have a larger scale of the fundus, and maybe earlier detection of subretinal fluid is possible. And it has been published that the shaggy photoreceptors may be typical of melanomas that may be doubted, maybe true or not true. This is seen on the OCT on your left with these shaggy photoreceptors, maybe typical or maybe not. So again, what is a nevus and what is a melanoma? So have your personal guess. What you see are very flat, pigmented or non-pigmented lesions, particularly the lesion on your, the second lesion from the left in the lower line, and just look what happened. And that lesion on the left had a biopsy, and it turned out to be definitely a malignant melanoma in the histology. And these two lesions look harmless, but you just have to wait long enough. And what you see in the left lesion 14 years later is definitely gross. And the lesion on your right, there's no doubt, grows 21 years later after the first presentation of the patient. So it takes time. And as I will point out later in my talk, of course, as in all other malignant tumors, it makes sense to detect a malignant lesion as early as possible to have the best chance to treat that patient. Some years ago, there was I think a very basic or very essential study from the European Ophthalmic Oncology group. And that group looked at 45 fatal small choroidal melanomas with a thickness of 3 millimeters or less, so rather small tumors. And one very important take-home message is there was no metastasis in cases where the largest basal diameter was less than 3 millimeter. And the second basal take-home message is only just a third of the patient, these tumors had grown before metastasis occurred. And the third take-home message is neither the number nor the type of the TFSM or classification risk factors were able to predict metastasis. So the classification TFSOM, as just shown, shows risk factors for growth, but that necessarily does not correlate to metastasis. These are some lesions of that study, of the small fatal choroidal melanoma study, and some of these are very small lesions. And these 6 other patients from that study, and not all of these lesions probably we will see that these do not look very dangerous from the clinical point of view, but all these patients with all these tumors have died of metastasis. Uveal melanoma is now very much evaluated, and we know a lot of genetic findings and genetic types to define the risk of the tumor. And you'll see these on this graph or this table. And the most important genetic finding in a uveal melanoma is monosomy 3. So it's a somatic mutations, and if a patient has monosomy 3 in the tumor, it's somatic, not in the blood, so in the tumor, metastasis may occur in over 19% of the patient. That correlates to a somatic BAP1 mutation, and there are another genes which are now explored, and GNRQ, GNR11 mutation is important. I will go into that mutation and that gene later in my talk. And there are 2 others, SF3B1 mutations and what is called IFAX mutations in the clinical routine. And these, again, are cofactors describing an increased risk of late-stage metastasis or a reduced risk of metastasis. So we now have a whole bunch of genetic findings and genetic typing. And so we are able, if we get the tumor cell, to predict metastases, as we can't do it in any other solid tumor of adults. So monosomy 3 is one of the most important genetic findings in uveal melanoma to predict metastasis. This is shown in this graph. That's from our group. Other groups have shown just the same results. And if you look at monosomy 3, that's a red graph, the risk of getting metastases is more than 90%. And on the other hand, if you got disomy 3, so monosomy 3 is the chromosome 3 is preserved, the risk of very low, and the patient have an excellent prognosis for survival. So a lot of groups have looked whether the risk factors for growth, if we just have shown from the Shields group and the classification of the Shields group, are associated with malignant transformation. And the Harbour group did that some years ago. They looked at more than 200 melanocytic lesions and did a genetic typing of the tumor, and they correlated these tumors with the known clinical risk factors for growth, as just shown recently. And what they found is just age and thickness was relevant. And all the other parameters like largest biometer, subretinal fluid, lipofuscin, growth, location to the optic disc, gender, reflectivity, and something else was just not significant in terms of genetic risk factors, in particular monosomy 3. So we all know that patients getting metastases have a very poor prognosis. And that was a clinical study that was published, or a review that was published some years ago. And they looked at all the treatment modalities which were available at that time, including anti-angiogenic treatment. Oh God, anti-angiogenic treatment. Chemotherapy, immunotherapy, kinases, and direct liver treatment. And if you just look at the Kaplan-Meier calculation, these patients had no chance. The risk was very high, and it has no impact on the survival of the patients. The first drug which was licensed to treat metastatic uveal melanoma was tebentafusp. And that was first published in 2022. And it's a bispecific fusion proteins which recognize tumor antigens presented by HLA molecules on the tumor surface of the tumor cells. So it can be only used on a specific group of patients having a specific HLL molecule on their surface. So that has to be typed before. And it shows the left graph on the left how that works. And that has improved the survival a bit. If you look at these two graphs, the orange one is tebentafusp and the other is a control. Tebentafusp do a bit better in the follow-up, but at the end, in 5 years, there's not a difference. And if you just look at the progression-free survival, again with tebentafusp and controls, it's a bit better, but at the end, in 30 or 36 months, there's no difference. So we have to look, and there's no particular interest in protein kinase inhibitors. Daravosertib, we all have to learn these new drug names, and the groups are looking whether that may be useful, and we have to follow the publications and the papers which are now published on that drug. And then maybe hope that we at least may reduce large tumors before treatment to make them accessible for radiation treatment, but that's on the bench, and we have to wait what will turn out as a helpful treatment. So what are the chances to improve the survival of patients with uveal melanoma? And we and other groups have looked at small and large tumors which monosomy 3. That was a study where we had the transretinal biopsy, and in small tumors which were treated by brachytherapy, and in large tumors treated by nucleation. So that were tumors with a height of 3.8 millimeters, small tumors, and large tumors 10.5 millimeter thickness in the mean. And the survival of these patients was different in the two groups. If you look at the monosomy 3 brachytherapy group, that is the orange line, compared to the M3 enucleation group, that is the blue line, you see there's a difference. So if patients with a monosomy 3 are detected earlier, their survival is better than if they just are not detected. Patients with a monosomy 3 in the biopsy brachytherapy group had a significantly better survival rate than patients with monosomy 3 in the large tumor group, which was the enucleation group. So it makes sense to detect monosomy 3 early. That's the only chance we currently have to improve the survival. That was published by other groups. That's the Liverpool group, which did a similar study, and they found again large tumors with monosomy 3 have a worse prognosis compared to small tumors with monosomy 3. So how to get the tumor cell? Unless you don't have the tumor cell, you just don't know. Just looking at the tumor with clinical methods, doing ultrasound, doing fluorescein, doing OCT, whatever you do, you will not find out what the genetic of the tumor is. So one of the techniques getting the tumor cell is transretinal biopsy. This is shown in that video. We do it at a mixed gauge vitrectomy. It's essential to use trocars in order not to disseminate tumor cells. Endolaser is required, and if required, and gas tamponade, and the specimen is fixed in formalin, and a native specimen is used for molecular genetic workup. This is such a patient. Biopsy was done 2 months after transrectal biopsy. No laser was used, and it's a very atraumatic treatment. And this is such a patient. That's an incidental finding of a 64 years old woman. In autofluorescence, there's some hyperfluorescence. Fluorescein angiogram really doesn't help a lot. And that's a patient 2 weeks after biopsy. Biopsy on the right shows you standard HE staining of the specimen. And Ki-67 staining shows you some mitosis, so it's not a very, very active tumor in histology. But if you look at the genetic of the tumor, there's monosomy 3. The upper graph is from the blood and shows you 2 peaks on 2 chromosomes for 2 chromosome 3, and the tumor sample shows you 1 chromosome 3 is missing, so it's monosomy 3. So this small clinical inapparent tumor or not tumor has a high risk of getting metastasis and should be treated, of course. There's now a large interest in doing liquid biopsy. Intraocular biopsy, of course, is an intraocular procedure. You need vitrectomy or not. At least you have to go inside the eye. And that has all the risk we know, intraocular hemorrhage, retinal detachment, whatever may occur. So the LIBIC group looked at techniques detecting circulating in tumor cells from patients with small choroidal melanocytic lesions. That has been published some years ago in ophthalmology. And they looked at circulating tumor cells, which were detected in 25 out of 47 patients in that group. And histology was confirmed in 22 of these 25 patients, and 17 patients had there's a typographical mistake. It's not trisomy 3, it's monosomy 3. And there was no clinical difference observed between patients with monosomy 3 for that typographical monosomy 3 and those with disomy 3. Sorry for the confusion. So that may be a technique to detect with liquid biopsies free circulating tumor cells. But there's an intensive discussion whether that may work and may be used in clinical routine. It's far away from being used in the clinical routine. And one of the limitation of that study was that the molecular genetic workup was not done in the biopsy specimen. So the tumor cells were not compared to the circulating tumor cells in the peripheral blood. So we'll look and see, but liquid biopsy definitely will become a technique in order to get a genetic workup of uveal melanomas. So what are the conclusions? Melanocytic choroidal tumors with a base diameter of less than 3 mm do not metastasize. I think that it's a good guideline for handling patients in the clinical routine which occur with such lesions of less than 3 mm basal diameter. Age and tumor size are key risk factors for metastases, as in all other adult solid tumors, which is not surprising. Multimodal imaging can detect risk factors for tumor growth, but not for the risk of metastasis. And transrectal biopsy and genetic profiling are better in identifying high-risk melanocytic choroidal melanomas than just clinical and histopathological findings alone. Should we make a stop at that stage for some questions, or should we go on?
We can ask anyone have a question from the audience. Maybe I have a small question, Professor.
Yeah.
Right now I'm outside in the center. And what about cataract surgery if we have an iris melanoma stage 1? Is there any risk if it's not
No.
on course, is already at stage 1 tumor is no problem?
No.
We
No,
know
it
don't need
doesn't change anything. It doesn't change
don't-
anything. So it does not increase the risk of metastasis.
okay.
It's a problem to do biopsy in iris melanomas. I'm short of time already now. But there's some tendency that iris melanomas have a higher risk of dissemination tumor cells. So if you're doing the cataract surgery, do not biopsy the tumor, which is
Okay.
only true for iris melanomas, not for choroidal melanomas. Iris melanomas disseminate, and
Okay.
nobody knows why. So they have a very low risk of metastasis. So don't do a biopsy in an iris tumor, not in choroidal tumor.
Sure. Thank you. Any further question from the public? No. We can
Okay.
go ahead.
So malignant melanomas of uveal and radiotherapy. Just a very short survey. The working horse of treating uveal melanomas are radioactive applicators. And there are two different types available. Most of the European centers use ruthenium plugs, as shown on the left, and most of the American centers use iodine plugs, as shown on your right. They differ in the depth distribution. So ruthenium plugs have a more limited depth distribution of radiation, and iodine plugs have a more enhanced depth distribution, which is seen on the isodose on the right. You see the 20 gray isodose is reaching nearly the opposite retina in the iodine plug. So these are the working horses in European centers. Ruthenium plugs, these are beta particles with gamma background, and an excellent shielding. They have a long half-life of a year that makes the treatment more cost-effective. These applicators can be used for 2 years at least, and that reduces, of course, the cost. There are a lot of applicators available to fit all the clinical situations: large tumors, small tumors, adjacent tumors to the optic disc. Whatever you see, you will get an appropriate ruthenium plug for that. This is such a patient with a uveal melanoma in the temporal superior arcade, 15 months after brachytherapy, with a complete regression of the tumor. And this is another technique which you probably may prefer if you have a tumor close to the macula, and what you use is an off-center radiation. So you put the plug a bit eccentric, and to limit the radiation damage to the posterior pole that is seen 3 years after treatment on your right. Iodine plugs use iodine 125. This is a very low energy gamma emitter with an average photon energy of 27 keV. It has a short half-life of 60 days, which makes that treatment very, very expensive, and the seeds are commercially available. The next radiation treatment you may use is external beam radiotherapy, and you're probably all aware the difference in the depth dose distribution in the different sources or the different radiation types. That is cobalt, these are electrons, these are photons, and that shows you what the advantage of protons are. Protons have what is called a Bragg peak. So they have a peak at the end of their which is makes it possible to have a low radiation in the field and complete no radiation at the end of the field. And that's used with a trick. That again is a dose distribution with a Bragg peak. And the trick is to just add several Bragg peaks. And so you get a very advantage dose distribution with no radiation at the end of the field and low radiation at the entry of the field. And of course, that is widely used, but you need a cyclotron. That again shows you the technique. It's very expensive treated. You need a cyclotron, and the cyclotron is really a very expensive device. So it's limited to centers throughout Europe, and it's not, of course, available in every center. Surgical treatment is another treatment of handling uveal melanomas, and what is known from clinical routine is that you leave a large tumor in the eye, which is such radiated, you get what is called a toxic tumor syndrome. And that is the garbage bag, I would like to call it, from the vitrectomy, with what has been removed during an endoresection from the eye with a malignant melanoma. So that's now all in the bag. And probably we all consent that it's better to have that tumor in the back and not in the eye. So resection, of course, is a good technique. And if it's available, and there are two different techniques for resection. One is transcranial resection, and that is done with a lamellar scale dissection, as shown on the slides on the left. It's almost done in arterial hypertension because of the risk of bleeding and hemorrhages. Postoperative brachytherapy is performed at the base of the tumor. And the best indication for doing transcranial resection are highly prominent melanomas of the anterior uvula with a small base. These tumors are really made for transcranial resection, and transcranial resection is the best treatment in these tumors. Transretinal resection of malignant melanomas is another technique, of course, preferably in large tumors of the posterior pole. That is a large mushroom-shaped tumor at the posterior pole. And neoadjuvant radiotherapy is performed for resection in order to have no dissemination of viable tumor cells at the time of surgery. Then PFCL is used to protect the posterior pole of the eye for bleedings, shown on the video on the left, where the PFCL is covering the whole posterior pole. Then the tumor is removed with a vitreous cutter, and PFCL is replaced with silicone. and almost never use gas or air tamponade. Some patients have been published where there has been embolism of air or gas, and patients had a fatal outcome when air or gas was used, and it may end up with an embolism of air and gas with a fatal outcome. So almost never use air or gas, use silicone probably for tamponade of the retina. That is a patient 2 years after treatment, the same patient. It's another patient with a large mushroom chain tumor close to the optic disc, and that, of course, is just made for transcranial section. That is the same patient. I think it's 2 years after treatment, and very good result. So that's melanomas. Pseudomelanomas may confuse
Professor,
yeah.
just a moment, we have two questions.
Oh, sorry, excuse me. Yeah,
The first one, OCT angiography, I
doesn't
think
help.
doesn't have any
No, we don't do it.
any significant
No,
significance in the diagnosis.
no.
But in hemangioma, I
That's
think
different. That's different.
yes.
It's later
So
to talk, yeah.
yes,
But,
the other question, yes, the other
you probably
question.
do not need any angiogram in most of the melanomas. You just don't need it. Yeah. Yeah.
We need mostly photo documentation and ultrasound measurement, or maybe OCT. Um, and fluorescein angiography is not so relevant in the follow-up
No. No.
of tumor of
Yeah.
choroidal melanoma. The other question is about follow-up and checkups. Um, how you advise to follow up? You have a special regime.
It's a controversy. And my personal approach is if you see a new patient never seen before and there's no history and you see a melanocytic lesion, it makes sense to see the patient 3 months again. And if nothing changed, I like to see him in 6 months again. If nothing changed, I like to see him in a year. So the first follow-up visit should be 3 months, 6 months, and a year, and then every year. Depends a bit on the risk factors for growth, not for metastasis. And if you see a patient who has a basal diameter of more than 3 millimeters, always discuss with the patient 3 strategies. The one strategy is just wait and follow. The second strategy is treat it. It may be benign, but if it's a peripheral tumor, let's say in the nasal periphery, local radiation has low morbidity, and you can just treat the tumor, and then it's gone. And the second treatment strategy is we can do a biopsy to find more. And it's always up to the patient to decide what strategy he will follow. Just follow the patient, the tumor, treating the tumor, or having a biopsy for genetic workup.
Thank you very much. So we can go ahead again.
Yeah, so look into my clock in order not to be too long. Yeah. So pseudomelanomas may confuse the ophthalmologist. And these are 6 different tumors in an adult patient. And just look at it, and just one message is none of this is a melanoma. And just consider what would you think? What are these tumors? The tumor on the lower right is not a melanoma, not a uveal melanoma. And so just to show what it is, one is a carcinoid, the other is a neuroepithelial tumor. The tumor on the upper right is leiomyoma, which is really rare. Schwannoma is rare. Hemangioma will be discussed later in the talk. And on the right, you see a metastasis of a cutaneous melanoma, which looks very much like a choroidal melanoma, primary choroidal melanoma. But of course, it's not a choroidal melanoma, it's a metastasis. And I will show you another case later in my talk. So if you just would like to find out how to treat these tumors and what are these tumors, again, biopsy, of course, is a technique to find out what tumor it is. I will just show it later in my talk. That's a very famous paper of Jerry Shields some years ago, and he just published in his experience in his clinic what were the most common pseudomelanomas, the most wrong diagnosis for patients referred to his clinic. And it's the most frequent is at the top, and of course it's Nevus. And the next are what is called peripheral exudative hemorrhagic choroidenopathy, pigmented epithelial hyperplasia, subretinal hemorrhage, neovascular AMD, congenital pigmental hematoma, choroidal hemangiomas, and again, intraocular metastasis. So that is a patient, we discussed Nevus already, but that is a patient who was referred because of intraocular mass, and it looks a bit pigmented. And that patient had a biopsy, and it turned out to be a metastasis from an unknown prostate cancer that is shown in the PSA staining. It was a metastasis of prostate cancer the patient wasn't aware of. And that is another tumor. You may, just from a clinical point of view, you may look at it very long, but probably you will find out that was a vasoproliferative tumor of the retina. And this is a patient who has on both eyes peripheral lesions or masses. And these are typical patients with a peripheral exudative hemorrhagic choroidenopathy. And then in most patients, what helps is these are in the most patients bilateral. And these are retinal detachments, temporal, bilateral, and often associated with exudative AMD. They almost never are nasal. So if you see on both eyes these temporal lesions, probably it's not a malignant melanoma. And there has been a very nice paper some years ago from the Lausanne group, and they showed that the anatomic base of these lesions were polypoid changes in the choroid, pretty much the same as we know from from P4C. Uveal effusion syndrome may be puzzling, but these are circular serous detachment of the peripheral choroid, and the intraocular pressure is normal. And there's no shedding in diaphonoscopy, and there are three different types. Won't go into details with respect to the time, but these are almost, in most patients, circular, and the pressure is normal. It's not the hypotony after surgery or trauma or whatever else. Then they have a normal intraocular pressure. That's the MRI imaging of the same patient. Hypertrophy of the retinal pigmented epithelium may be confused. This is a very typical bear step hypertrophy. And that is a typical hypertrophy of the retinal pigmented epithelium in the periphery. It's black. It's dark black, very black. Nevus is not as black as hypertrophy of the retinal pigmented epithelium, and they change. That the same patients 21 years later, and then they just look at like a giant paving stone degeneration of the retina. Morphology may help a bit. There are changes in the pigmented epithelium, subretinal clefts, and the atrophy of the photoreceptor layer if you do OCT, but you do not need OCT most of the patient. This is a congenital hematoma of the retinal pigmented epithelium. That's a diagnosis which is more normally made in young children, on the age of 8, 9, 7 years. And that's a sentinel type. There are peripheral types. And that is a hematoma. And what is characteristic is they always have something like, which is an epiretinal membrane overlying that lesion, and they do not change. They are not malignant and do not require any treatment. And you may see some patients where you may be confused, is this an age-related macular degeneration or is that a tumor? And that lesion looks pretty much like a malignant melanoma, but you have seen the patient 6 weeks before the left image or left photograph was taken. It's the same patient, of course, it's AMD. But you may be confused. And in rare cases, in some cases, fluorescein angiogram may be helpful to detect the tumor. Intraocular metastasis has already been addressed with a patient with a prostate cancer. And we ought to be aware that intraocular metastases are common. And it's estimated that at least in Germany, there are about 5,000 new cases per year in Germany. It's much more than uveal melanoma. And in one of the two patients, breast cancer is a primary tumor. So the most frequent primary tumor in intraocular metastases is breast cancer, and you should be aware men can become breast cancer and metastasis to the eye, which is not frequent, but the prognosis in these patients is very bad if a man becomes a breast cancer. In one of the patients, it's bronchial cancer is a primary tumor, but almost any primary tumor can metastasis to the eye. I will show you some cases. That's a typical clinical case. These are mostly amelanotic flat biconvex tumors, often accompanied by exudative attachment, often multifocal, often bilateral. And there is such a patient with a bilateral metastasis from a lung cancer in both eyes. And there is a patient with bilateral metastasis with a leopard print-like pigmentation with bilateral metastasis of breast cancer. Metastasis may occur in the anterior segment, the patients having intraocular or anterior segment metastases because of lung cancer or renal cell carcinoma. There is a patient who has a metastasis to the choroid because of a carcinoid. You have seen the patient prior in the talk. And there is a patient with a very rare metastasis to the choroid because of the hemangioendothelioma. So just everything may metastasize. I mean, it may help to do biopsy of the tumor when the primary is unknown. And I just would like to show you that in these 3 patients, that was a patient who was unaware of having an adenocarcinoma of the lung. It's a biopsy. That patient has a prostate cancer. You have seen that patient prior in my talk. And that patient had a thyroid cancer. And that shows you the globulin staining of the biopsy leading to the diagnosis of the primary cancer. So it may be helpful in some cases, if you don't know the primary, to do the biopsy of the intraocular lesion to find out what the source of the intraocular metastasis may be. Intraocular metastases of cutaneous melanomas have already been addressed. They look pretty much like a primary choroidal melanoma and have lipofuscin, but they do grow, very rapidly grow. It's the same patient 3 months later, having all the specific signs of primary uveal melanoma, lipofuscin and pigmentation, but it's a metastasis. And if you see such a patient with multifocal pigmented tumors, as shown on your right, probably cutaneous melanoma is the source of the tumor and its metastasis. Just a short scheme, what should you do if you see a patient with uveal metastases? Search for the primary tumor. If you do not know the primary tumor, consider intraocular biopsy to make a diagnosis. In diffuse metastases, you of course can do chemotherapy, external beam radiotherapy, immunotherapy, whatever may be available, or even hospice care. In local intraocular metastases, external beam radiotherapy or chemotherapy may be helpful. And you may see focal metastases, just a focal tumor, and then brachytherapy or even PDT may be evaluated or evaluated. Yeah. So at the end of my talk, I have just a short look to my clock. I would like to talk on vascular tumors. Should we discuss any questions if available? Made.
Any questions, colleagues? No, I think we can go ahead.
A lot of stuff, probably. Okay, vascular tumors and vascular malformations. And you probably all know retinal hemangioblastomas. Once you've seen such an impressive case, you will never overlook such a tumor. And retinal hemangioblastomas are benign vascular tumors with capillary vessels and reactive gliosis. They may be very small, as shown on your left, and may be very large with enlarged feeder vessels, as shown on your right. And that is a typical tumor distant from the optic disc with exudates at the posterior pole in the macula. And if you just do an angiogram, these angiograms are very impressive. You see these very enlarged feeder vessels and retinal veins are enlarged, and you see a massive leakage of fluorescein in the angiogram, and a whole lot of fluorescein will be leaked, and the whole tumor will be just covered with fluorescein, and that is very typical, of course. There may be small tumors, and some of these tumors may be overlooked in clinical checkup, and it's a good idea to do fluorescein in these patients. And in fluorescein, you will see all these tumors because they all leak and they all appear in fluorescein angiogram, even small tumors which may be overlooked if you just do a clinical routine. Pitfalls in diagnosis are juxtapapillary tumors because these juxtapapillary tumors do not have feeder vessels. They are just sitting close to the optic disc, going ex or endophytic at the optic disc, and they are just a large mass close to the optic disc and have no feeder vessels, but these are hemangioblastomas. That again are 2 patients, and it doesn't look like a juxtapapillary tumor, but if you do angiograms, you see that there's a juxtapapillary choroidal retinal hemangioma with leakage of dye in the late phase of the angiogram, and these are tricky and may be overlooked in a clinical examination. If you just do nothing or the patient is untreated, These tumors grow, they lead to tractional membranes, tractional detachment, as seen on the schematic drawing on your right. And that is a very complicated situation. And if the tumor has progressed so far, as shown in the schematic drawing on your right, it's very hard to treat these tumors. These eyes have a very bad prognosis. So it's essential to detect these tumors very early. Hemangioblastoma are not always associated with von Hippel-Lindau syndrome, and just in about half of the cases von Hippel-Lindau syndrome. Von Hippel-Lindau genes is very well known. It's a very small gene on chromosome 3p, and these patients have multiple large tumors. These are young patients, and there's no proven efficacy of systemic or local anti-VEGF therapy in retinal hemangioblastomas. You may find these in some textbooks or any presentations, but anti-VEGF drugs do not help. Unfortunately, they do not. That shows you again the manifestation of a von Hippel-Lindau syndrome, cerebellar angiomas, renal cell carcinomas, brainstem and spinal cord tumors, and epidemial and adrenal tumors, neuroendocrine tumors of the pancreas. So these patients have really problems, and they really have a burden in case of a von Hippel-Lindau syndrome. What are the treatment options? Small tumors may be treated with photocoagulation, and that is, if you detect a very small tumor, very effective. Photodynamic treatment has been discussed. The Liverpool group has published on that, and that has been affected in not very much tumors. A third of the patients may be treated effectively. There's no efficiency or no treatment efficiency of anti-VEGF treatment. And belzutifan now isn't the focus of interest. It has been developed for the treatment of renal cell carcinoma and von Hippel-Lindau syndrome, but it's shown that may be helpful in advanced von Hippel-Lindau cases. We'll show you some of the details in one slide just following. And brachytherapy and proton therapy may be used in tumors, of course, and vitreoretinal surgery only in very advanced cases with a very bad prognosis. So what about belzutifan? Belzutifan goes directly to what is called the hypoxia-inducible factor, HIF, and von Hippel-Lindau disease, both alleles are lost, and there's an activation of the HEY treat targets. Just if you look at the graph, you'll see that VEGF is a part of that cascade, but anti-VEGF doesn't work. And belzutifan is a hypoxia-inducible factor inhibitor. And it's very effective in renal cell carcinoma, and there are more and more papers dealing with capillary hemangiomas of the retina. And there is such a case, series reports which is published 4 months after treatment in the lower two images. And so there will be more papers on that. And it's one of the hopes we have, treating patients with an advanced von Hippel-Lindau angioma in the retina. Cavernous hemangiomas of the retina are mostly diagnosed as codes, but it's not codes. These are congenital vascular hematomas. They usually are incidental findings because they do not cause any problems, located in the periphery, may be associated with cutaneous and spinal lesions, and there's no treatment necessary. There are typical fluorescein angiogram findings, and these are cap-like filling defects, as shown here on the right. On the left, the image on the left, and the takeout. Sorry. Yeah. And again, some of these patients may have lesions close to the optic disc, and some of the patients may have a fibrous glial membranes on the surface of the lesions, but these are all cavernous hemangiomas. Vasoproliferative tumors of the retina, acquired vascular tumors of the retina, and nearly all these tumors are located in the temporal lower peripheral retina. They are composed predominantly of glial cells, and as shown here, they do not have any feeder vessels, and they differ from hemangioblastomas as seen for Hippel-Lindau disease. These may look like these tumors, but they have totally different fluorescein angiographic patterns as seen here, and have no feeder vessels, which makes a difference, and they may occur in some patients with retinitis pigmentosa. This is not uncommon that patients with retinitis pigmentosa have such vasoproliferative tumors. Congenital unilateral retinocephalic vascular malformation syndrome is a spectacular disease. And this is such a patient with such a malformation. If you do an angiogram, it looks spectacular with these enlargements and malformations and shunts. And these shunts may vary with time. They're associated with Weill-Mason syndrome, non-hereditary, and most of the patients are unilateral and maybe have some cerebral involvement, and these may change. It's a follow-up over 17 years of the same patient. And if you just look, there are some shunts disappearing, new shunts may occur, and there's another shunt and it looks different. So it's a very low understand. Just we don't know how that works. It's a high flow system and it may change and in a long time, but there's no treatment. So at the end, have a look at my clock. Yeah, it should fit. Would end up with choroidal hemangiomas. And choroidal hemangiomas are probably congenital and by diagnosed mostly between 40 and 50 years of age. And probably that is because they become exudative. And the typical clinical characteristic of such a tumor are discrete, round, orange-colored choroidal masses, as shown on the slide, on the image on the left. And there may be a pigment ring at the margin of the tumor, and most of these tumors have subretinal exudation, and they may be mistaken for sentinel serous retinopathy. These are small tumors. We've seen a lot of patients which have been treated for years with a diagnosis of sentinel serous chororetinopathy, and these hemangiomas may be small and just have exudation, but of course they are detected in angiogram. They may have an extensive exudative hemorrhage, which is seen on this slide, and they have a very typical fluorescein. So fluorescein is helpful, but you see in the very early phases, in the choroidal phase, before the retinal arterial phase, there's an early spider-like fluorescence of the of the tumor vessels, and the diffuse hyperfluorescence and the dye washout in the late phase. That's just typical, and it's just only seen in hemangiomas. And you see these typical vascular patterns in fluorescein and ICG angiogram on these slides, and there's a washout of the dye at the late phase. That's again another patient with a choroidal hemangioma. You see again these spider-like vessel formation in the very early phase of the angiogram, and that makes a diagnosis. I just skipped that slide. Choroidal, most of the hemangiomas are circumscribed. And that patient was a patient where we were unsure whether that is hemangioma or not, and that transrectal biopsy was that patient, and it shows you the typical histology with a large cavernous hemangioma. There's no doubt about what the diagnosis is, and it pretty much looks like a melanoma, but it's not. Luckily it's hemangioma. Hemangiomas, as you probably know, may be associated with Sturge-Weber syndrome, and that is what now is called a port wine stain lesion, which is addressing the Nevus flammeus. It's all located in the first branch of the trigeminal nerve. And these are considered to be a venous capillary malformation of the leptomeninx and the eye. And with intracerebral vascular malformations, a very bad secondary glaucoma, which is very hard to treat, and a diffuse, non-circumscribed choroidal hemangioma with a total retinal detachment. This is such a typical patient with Nevus flammeus on the right side of a face, and diffuse hemangioma of the choroid in Sturge-Weber syndrome. That's another patient with such a diffuse choroidal hemangioma. In the MR imaging on the right, you see that the hemangioma is just extending through the whole choroid, and this patient have a very bad secondary glaucoma, and of course a loss of vision because of the exudative, in some patients, total exudative retinal detachment. And the focus of the interest is now looking at the GNRQ, GNR11 gene. That gene occurred at the beginning of my talk when I showed you some of the genes which are involved in the pathogenesis of uveal melanoma. And GNRQ and GNR11 are genes which lead to the regulation of the signaling pathways and influence to the immune response to tumor cells. It's very interesting, and we do not have time to go into details, but that gene is interesting because it shows some of the differences in different mutations which will occur in diffuse choroidal hemangiomas. That makes a specific mutation on exon 4. In uveal melanoma, melanosis, and choroidal nevus, there's a specific mutation in exon 5. and in locus 209. And in circumscribed choroidal hemangiomas, interestingly, there's another mutation in the same locus in exon 5. So that's what we know on the mutations of these tumors, and probably we'll see more papers in the next future dealing with the difference in the with potential clinical use of these differences in these two tumors. But it shows that choroidal melanomas, Nevi, circumscribed choroidal hemangiomas, and diffuse melanomas all have some pathogenesis in common with GNRQ, GNR11 mutations, and that will be subject of basic clinical science in the next years. The best treatment of solitary choroidal hemangiomas is photodynamic treatment. Then there is a patient 2 months after PDT with complete resolution of the tumor, and luckily the laser and the substance, the drug, will not be available. And sometimes they are available and sometimes they are not available. And Zeiss has discontinued the laser needed to do PDT. So he may be in the future not available to do that type of treatment. But if you have a laser and if you get access to the drug, Verteporfin PDT is the best treatment. That's it. Thank you.
Thank you.
Yeah.
Perfect. Thank you, Mr. Professor Bornfeld, for this very informative talk about posterior segment tumors in the ophthalmology. And if anyone has a question, just raise your hand or write in the chat, please. Good. Everything was
too much stuff.
I think choroidal melanoma is a rare entity in the Near East and in the Arab region in general.
I think so. It's rare in China and in Japan, and in black patients. I don't know whether in the Arabic populations, I'm just not aware of the incidence of melanomas in the Arabic populations. In black patients, it's rare, and in Chinese patients and Japanese patients.
Yes.
Yeah.
Okay. Still no question. So thank you very much, Professor Bornfeld, taking time not only for this webinar, otherwise preparing for the webinar in English. I think
my pleasure.
It took
there was
more time.
one typographical error. The confusing trisomy with monosomy and disomy is unexcusable, and I just skipped that. But it was monosomy and disomy, not trisomy. I'm sorry for that. Yeah.
Yes. Thank you very much.
It's Murphy's law of PowerPoint presentation. There's always one typographical error in each presentation. That was the error. Yep.
Yes. Thank you very much. Take time sharing your experience with us. And we thank the organizer, Syrian Ophthalmologist Initiative, Dr. Ammar Al-Masri is one of the participants today. And thank you all attendees. Thank you, Professor, again.
Thank you. My pleasure. Goodbye.